Welcome everyone that's joining us today for our Mailman Center Grand Rounds. My name is Michelle Sladon and I'm the Associate Director of the Mailman Center. And today I have the pleasure of introducing our speaker, Dr. Pelham, who is a distinguished professor of psychology and psychiatry at Florida International University. And he is the director of the Center for Children and Families. He is a nationally and internationally known researcher on the assessment and treatment of children and adolescents with attention deficit hyperactivity disorder, ADHD. He has an impressive academic record, authoring or co-authoring almost 500 publications. At FIU, he has developed a summer treatment program for ADHD, which has been recognized nationally as a model. And today he's going to be talking to us about some of the work he's doing in his laboratory, studying the sequencing and behavioral and pharmacological treatments and the impact of medication on learning. And with that, I will turn it over to Dr. Pelham. I would also say that Dr. Pelham is going to be presenting a lot of information. He's going to be going through his slides quickly. He might be skipping through some slides, but he would be happy to share his slides with anyone that requests it. And I will put his email information in the chat for those of you who would like a copy of his slides. And with that, I would like to thank Dr. Pelham for joining us today and turn it over to him to talk about his research.
Thank you very much for that introduction. Can you hear me? Is this okay?
Yes, we can.
Sounds good. Okay, I'm very happy to be presenting today and pleased to have been invited back to UM to give a talk. We have some new research that I think is very interesting and quite relevant for people in the pediatric, behavioral pediatric, for example, field. So what I'm going to do is go through some slides, which probably are similar to slides that I had the last time I presented at UM, which is probably, I don't know, 5 or 6 years ago. And I'm going to go through those fairly quickly and try to get to 3 or 4 newer studies that we've done that I think are very interesting and you might find interesting also. So let's get started. This just gives my disclosures. Between 30 years ago and 20 years ago, I did lots of work with pharmaceutical companies. I haven't done any in 20 years. So I'm quite familiar with stimulant medications and working with pharmaceutical companies. Our lab, for example, developed Concerta for the manufacturer. And we did the first several studies on Adderall before Vyvanse was developed by Shire and so forth. So we've done lots of work with medication. I was lucky enough to be trained in graduate school in a lab with Dan and Sue O'Leary, who were some of the originators of behavioral treatment for kids. And so I've been doing this for a long time, and I hope to be able to share a lot of good information with you. This is a short list of all the people that work with us at FIU at the Center for Children and Families. I welcome anybody from UM to come over and visit us. We have a lot of stuff going on, and we're happy to share. I think almost everybody knows about the prevalence of ADHD now, that it's the most common behavioral referral to healthcare professionals, the most common diagnosis in special ed, the most common behavior problem in regular ed classrooms, and one of the most common academic problems in regular ed classrooms also, and the most common diagnosis in mental health facilities for children. There are 3 ADHD boys at a picnic doing something that they're enjoying but would make their mother very embarrassed. That's French fries in their noses. And that's an ADHD girl at the same picnic. And if you haven't read these and you're a person who works with children, I would recommend that you go to Amazon and buy copies of the Captain Underpants books. They're about children with ADHD, and all the kids in the country have read them and are still reading them. They're very good descriptions of a typical ADHD kid in a school setting. ADHD has had a variety of names over the years. I've been working in the field since minimal brain dysfunction was the term that people used, going through hyperkinetic impulse disorder or hyperkinetic reaction of childhood, attention deficit disorder with and without hyperactivity, and the current DSM definition of ADHD. So the core symptoms of ADHD have been the same over all of those names for the past 50 years: inattention, impulsivity, and hyperactivity. What's varied is how they're defined and how they're studied. The current DSM-5 definition is the same as DSM-4 for the most part: 6 symptoms of inattention or hyperactivity, or hyperactivity impulsivity. And that gets you diagnosed as having ADHD. I want to stop talking about diagnosis just to say that that the most important part of diagnosing ADHD and treating ADHD is not the ADHD symptoms, not the DSM symptoms of ADHD. It's the impairment that's associated with those. And impairment wasn't in the DSM at all until DSM-4, I think, maybe DSM-3 a little bit. But impairment is the key thing to think about for a clinician who's working with kids with ADHD. Of course, it's what parents talk about. Parents don't talk about symptoms. They talk about the problems the child is having at school and at home. So impairment is the key thing that we as clinicians need to be thinking about, and we need to focus on the kids' impairments, finding out what those are, what's causing them, and what we can do to change those. There's common psychiatric or psychological or pediatric comorbidity with ADHD, and not as common as people think. For example, I always have people say, oh, anxiety disorders are really commonly comorbid with ADHD. Actually, they're not commonly comorbid at all with ADHD. Maybe Tourette's is a little bit, but most ADHD kids don't have Tourette's, just like not many other kids do. The most common comorbidity with ADHD are learning problems, language and communication problems, oppositional defiant disorder, and conduct disorder. With ODD and learning disorders, learning disabilities, the two most common comorbidities, and ones that require a lot of attention when kids are being treated. And the point of this, again, is to say that it's not DSM symptoms that are important, it's impairment. They're not important for etiology, for understanding ADHD or the mechanisms of dysfunction in ADHD. They're really not important at all for treatment conceptualization and implementation, and they're not important for predicting outcome. What is important is the domains of functional impairment that the children have. Their relationships with their parents and other adults, their relationship with peers and siblings, and their academic achievement in school, behavioral functioning in school. So impairment is the whole bailiwick in terms of treatment for kids with ADHD. Assessing them and treating them is figuring out what the functional impairments are and what one can do to treat those. And a reason for this actually is something that that we as clinicians need to be, and professionals need to be talking to parents about, and making sure that kids are getting referred if they have impairments in their daily life functioning, not symptoms of ADHD, but if they have impairments in their daily life functioning. And that's impairments in peer relationships, in their parents' parenting, or the family issues, and in academic achievement. And our goal of treatment is to minimize impairments and to maximize adaptive skills, not to eliminate the symptoms of ADHD. I don't think we can do that for most kids with ADHD. We can't eliminate attention problems or eliminate hyperactivity or eliminate impulse control. We can eliminate the impairments that go along with that and the behaviors that get kids into problems if they have slightly higher levels of those than other children do. So the whole ball game in treatment is figuring out how to work on the kids' impairments and how to minimize their impairments and maximize their adaptive functioning. Why is it important to treat ADHD in childhood? In the last 20 years, especially in the last 20 years, we have more and more longitudinal studies that show us that ADHD children continue to have serious problems as they move through life. I've had to adapt this slide over the years as it becomes clear that ADHD kids have problematic outcomes all the way through school, all the way through high school, college if they are eligible to go to college and can get into college, And then the literature in the last decade has shown that their problems continue until they're into adulthood with their vocational and financial problems and interpersonal problems and perhaps problems with substance use. So ADHD kids have a serious difficulty as children that continues, even worsens to some extent in adolescence and continues into adulthood. Sadly, we treat very few adults with ADHD in treatment facilities. And the reason is that adults with ADHD, kids with ADHD have never thought that they had problems. So typical ADHD kid is not aware that they have difficulties in paying attention. They have positive attributional biases, and they think that other people are the people to blame for the problems, not themselves. And that those biases continue into adulthood. So the outcomes for adults with ADHD are not good, and they need to continue to receive treatment. So what is effective evidence-based treatment for ADHD in childhood? These are some of the treatments that have been used over decades. The most common treatments are the ones at the top: one-to-one therapy or counseling, cognitive therapy, office-based play therapy, still diets like taking away sugar and so forth, allergy treatments, occupational therapy, pet therapy or hippotherapy, dietary supplements, mindfulness training. All of those are common treatments for ADHD around the country, and none of those are evidence-based treatments. That is, none of those have any evidence saying that they're helpful to kids with ADHD. And all of them have been tried and shown to be found wanting. Sadly, the clinical practices of people working with kids with ADHD are typically far behind what the science shows. So we published a study on occupational therapy 4 years ago that shows that occupational therapy doesn't work at all with kids with ADHD. I went online today to see what Google says about occupational therapy, and there are 10 times as many postings about why occupational therapy is great and where you can get it than there were citations for our paper that was in a scientific journal. The same thing is true for other types of interventions. Mindfulness training, for example, is widely said to be useful for kids with ADHD. And one of the few really good studies of mindfulness training was done by one of your interns, Marcela Ramos, in our lab. And her study, which was published this past summer, shows that mindfulness training is completely ineffective for kids with ADHD. So it's not something that we should be recommending. Can you hear me?
Yes, we can.
My slides were not moving ahead the way I wanted. So those were treatments that don't work. What treatments do work for kids with ADHD? Well, we've known for 20 years, we've known for actually 40 years that stimulant drugs are effective short-term treatments for children with ADHD. And that's their effectiveness is limited to short-term treatments. We've known for a good 30 years that behavioral treatments are effective for kids with ADHD. And for 20 years, the treatment of choice has been combining those two approaches to treatment of ADHD, the combination of stimulants and behavior modification, with the debates being, do all kids need both treatments? Which one do you start with? How much do you give of each one if you're doing a combination, and so forth? And I hope to clear up some of the questions that people have about that today. Despite the fact that the clear, as you'll see in a few minutes, this clear recommendation of all the leading professional societies now is that combined treatment is important. Psychosocial treatment is the most appropriate first-line treatment for ADHD, with medication as the second line. At the same time, the treatment that ADHD kids get in real-world settings is by far more often medication first than psychosocial treatment first. And that's true, even though these are guidelines on treatment sequencing from the past few years. And what I wanted to show you is the current guidelines on treatment and sequencing. So in 2019 and in 2020, two leading medical societies, the AAP, American Academy of Pediatrics, and Society for Developmental Behavioral Pediatrics, revised their guidelines for treatment of ADHD. And the guidelines are similar. And the guidelines are that behavior therapy and medication should be used ideally together to treat children with ADHD. The only debate is that the AAP said that they could be used in any order and any type of combination. SDBP took an additional step of saying that it makes most sense to start treatment for children with ADHD, for children with what's called complex ADHD. And basically complex ADHD is anybody with a serious case of ADHD. And to start treatment with psychosocial treatments and psychoeducational treatments, and then add medication. AAP said you can do them both at the same time. So the consensus now among professionals is combined treatment, psychosocial, behavioral treatment, and pharmacological treatment is the standard of care for children with ADHD. And the important question is, how does a clinician figure out the sequence in which to do those and the doses to be used? I like this statement a lot. This is the Society for Developmental Behavioral Pediatrics key action statement about what treatments work for kids with ADHD and how it should be utilized. And I would refer you to their set of guidelines, which are a series of articles in February 2020, Journal of Developmental Behavioral Pediatrics. They provide excellent guidelines for treatment of ADHD. Now, despite the fact that both AAP and SDBP now recommend combined treatments, and in the case of SDBP, they recommend starting with behavioral treatment, despite that, medication is still by far the most widely used intervention for children with ADHD. In our summer treatment programs that we run at FIU every year, the likelihood if a child shows up for treatment with us is that they have been medicated already before they've gotten to us. They have not had psychosocial treatment. They've not had any kind of educational treatment or psychotherapy. They have almost always had medication. But still by far the most common treatment for kids with ADHD. What should be the most common components of effective treatment for ADHD are behavioral interventions, and the three parts of that, and then medication as an adjunct. And for the behavioral intervention, it's focusing on the domains of impairment that the kids have. That is impairment in the home setting. To do that, you have to do behavioral parent training, like the the excellent parent training program that you guys provide. And we do the same thing at FIU. It involves a behavioral school intervention and making sure that the school district is doing what they need to be doing to provide excellent intervention for a child in the classroom setting. And then it's intervention with the kids if they have problems with other children, for example, or need some kind of extra help in the classroom setting that involves academic functioning. So you're working with parents and you're working with teachers and you're working with kids, all as a function of effective behavioral treatment for kids with ADHD. And medication, according to SDBP and AAP now, is an adjunct for the psychosocial approaches to treatment. I don't think I need to say this slide. I'll let you get this later. So what are the beneficial short-term effects of treatments for kids with ADHD? And essentially this slide and several others, and I'm going to skip through some of these pretty quickly, say that there's lots of data showing that one can in fact improve the areas of impairment that are common for kids with ADHD with intervention. And the intervention that works the best is intervention that is behaviorally based, the behavioral treatment and the classroom-based interventions that teachers can do with kids, not medication. Medication has beneficial short-term effects, beneficial short-term effects, but they do not translate into long-term benefit. Medication is easy to use to decrease classroom disruption, but the moment the medication wears off, then that benefit is completely gone. That's the single biggest problem with medication, is there's no residual benefit left when the medication wears off. And since stimulant drugs can't be taken 24 hours a day because of the nature of the drugs, they can't be used to deal entirely with the child's problems and impairment. What are the big limitations of pharmacological interventions? I already mentioned a couple of those. The biggest limitation of pharmacological interventions is number 9 here, the lack of evidence for long-term benefits. It's absolutely clear that medication improves short-term functioning in kids with ADHD. If somebody kidnapped me and said, here's my ADHD child, I'd like you to make them better in the next hour, or I'm going to cause severe harm to you, I would say, well, do you have any medication? Because I know that works, and it works really quickly. The problem with the medication is it doesn't have any beneficial effects after it wears off. And the last point here is an important one, number 11. I have lots of friends who are researchers in the on the biological side of things and understanding ADHD and child behavior, and they are uniformly of the belief that we don't know at all what is going on in kids' brains when we give a stimulant drug to them. We know nothing about, and we know nothing about the long-term effects of that. And over the last 20 years, the dosing that has been used for stimulant drugs in ADHD kids has gone way up. So most kids are taking very high doses of medication compared to what kids took in the 1990s, for example. We do not know what the effects are of long-term ingestion of a CNS stimulant drug. And most of the people I know in that field say, if I ask directly, I wouldn't put my child on a stimulant drug for 10 years because I don't know what the effects are going to be on his or her brain. Okay, these are just... Okay, so summary about treatment, parent training, always use treatment, always do parent training, always do a school intervention because there are always going to be impairments in those two domains. And then always do an intervention with the child if you have a peer relationship problem. Peer relationships are the hardest thing to treat in kids with ADHD. And so they're not usually included in the frontline interventions. Usually it's parent training and school intervention for that. And we recommend using medication in low doses as a short-term adjunct when the behavioral treatments are insufficient. Okay, what do we know about the studies of comparative and combined treatments? Because again, now combined treatments are the standard of care that are recommended by the 2 leading pediatric societies for working with kids with ADHD. I would imagine a substantial number of you were still wearing diapers when the NIMH MTA study was done. You may have no idea what I'm talking about, but NIMH did a very large study in the mid-1990s to look at what the best treatment was for kids with ADHD. The conclusion of that study was, depending on how you read it, was that combined treatment, psychosocial and pharmacological, was probably the best treatment, but there were a lot of caveats for it. The biggest caveat are these questions here. If we accept that combined treatment is good, which one should we start first? Should we start with medication first and then use psychosocial treatment to deal with the residual effects that are not taken care of by medication? Or should we do it in the opposite order? Or should we always combine them and use minimal doses of the 2, as minimal as we can? Or do we prioritize doing the psychosocial because there are more risks associated with the drug? So those are the questions that one has to deal with now, both in research and in clinical interventions, is how do you combine these 2 treatments? What I'm going to recommend to you through the course of the talk is that it makes a lot more sense to prioritize psychosocial treatment first and then use medication as necessary. When you do that, what I'll show you is that you'll end up losing much lower doses of medication than if you start with medication first before you do the psychosocial treatment. Lower doses of medication means lower side effects and lower risk and lower concerns about possible adverse effects of the medication on the central nervous system's functioning in a child who has to take it for a long period of time. Our research program over the last 20 years, and it has been 20 years, if you're a student or a resident listening to this talk, be aware that research isn't fast. It's very slow. Progress is very slow. It takes a decade or 2 decades before the results of a given study have any impact on practice in the field. And it's been a long haul for what we have done to reach the point where what we've been recommending for 20 years is what the field is now recommending, combined treatments. Okay, so this just says that over the past 20 years, we've had 5 studies funded by NIMH and the IS that look at effects of dosing and sequencing on treatment for kids with ADHD. And each one built on the one prior to it. I'll show you what the key studies in those grants were, and we'll go up to the latest, which is an analysis that Marcelo Ramos did a couple of months ago for one of our latest studies that just shocked us in terms of what it showed. So I'll go over that also. Okay. One of the best early studies that we did was one where we combined different doses of behavioral treatment and different doses of medication in the same study. We did it in our intensive summer treatment program, which is a day treatment program that looks like a summer camp for kids with ADHD. And in that camp, which lasts for 8 weeks, we have kids all day, every day for 8 weeks in the summertime, is a perfect venue for studying the effects, the short-term effects of behavioral treatment and the short-term effects of medication for kids with ADHD. So we designed a study about 15 years ago, actually, to look at different doses of medication and different doses of behavioral intervention, and therefore different doses of the combination of those 2 approaches. We could do it in a within subject manner because of the way we run the summer treatment program, and because both medication and behavioral interventions can produce acute effects that one can manipulate by having them in place on one day, not having them in place on the next day, or 1 week and not the next week. So it's easy to do combined treatment studies where you manipulate dosing of treatment with both behavioral interventions and medication and get answers about acute effects that hopefully will generalize to non-acute effects of treatment. So this study looked at different doses of medication from a very low dose. 0.15 milligrams per kilogram methylphenidate is a really low dose of medication, much lower than most pediatricians are prescribing for kids. 0.6 milligrams is a higher dose than most pediatricians are prescribing. It might be not uncommon for psychiatrists, but it's higher than most pediatricians are prescribing. So we used a typical dose, a really low dose, and a higher dose in these studies. And we combined the medication with the behavioral treatment. And what I want to show you, this is the design, essentially. It was using different doses of medication and varying those on a daily basis, because you can do that with stimulant drugs. The effects kick in right away, they wear off right away. So each day can be a new dose of the medication, for example. That's the design that we used. And we used 3 different doses of behavior modification. No behavior modification, low dose behavior modification, and high dose behavior modification. And we could do that by doing it a week at a time. It's a little more complicated to do it a day at a time, but a week at a time is pretty easy. So we had groups of children who were in treatment, and for a given week, they would have a very intensive behavioral treatment program in place in their group with counselors who are recording their behavior daily and looking at following activity rules, non-compliance, interrupting, and so forth. and giving the kids feedback constantly all day long about what they've done and giving them rewards for that and then consequences for it. So every kid had a point system, he had a daily report card, and we were manipulating a very intensive behavioral treatment or not manipulating it for a given period of time. And then since we were concurrently giving medication to all the kids, it was the opportunity to look at medication as an intervention, an acute intervention, behavioral treatment as an acute intervention, and the combination of the two as an acute intervention. I'll give you an example of what we were able to do in looking at that. This is from the classroom context in the STP. That is the daily frequency of classroom rule violations in our different conditions in this study. Now, remember I said we had no behavior modification days, we had low behavior modification days, and high behavior modification days. The high behavior modification was a very intensive point system that the counselors implemented, where the kids got points that they exchanged for rewards and for prizes and on a daily report card. The no BMOD condition involved no consequences. It was a very difficult task for our counselors who worked with the kids to implement an intervention in which there was no positive consequences and no negative consequences for children's behavior. But we did it and learned a lot of really interesting things from doing that. We crossed that with 3 different doses of medication. And this graph shows you what the results were. So if you look at the blue line in the upper left of the blue line, that is 60 classroom rule violations in a 60-minute classroom period for the average child if he was not having any behavioral intervention and not having any medication. So that's ADHD behavior without any intervention for the kids. Then if you look at the blue line going across the graph, that shows the effect of medication alone on classroom rule violations in the kids. So you got a big decrease with a low dose of medication, a bigger decrease if you double that dose, and a bigger decrease if you double the dose again. So medication had a clear effect in the kids. The red line, or excuse me, the black line is the effect of behavior modification. And what that shows is that with placebo and no medication, the kids' behavior in the classroom setting was exceptionally good. So a behavioral intervention, a high dose behavioral intervention where they earned a lot of points for their behavior and they could exchange their points for prizes and a daily report card and so forth, had a very positive effect on the kids. Sufficiently positive that there was very little room for improvement with medication. So what this study showed is that if you're doing behavior modification, then medication doesn't add much at all to that. You can do a low dose of behavior modification, which was a much reduced in intensity behavioral intervention, and that's pretty good. And that's pretty good. So this study suggested to us that by using low doses of behavioral intervention, we could dramatically improve the children's behavior in such a way that higher doses of medication were not necessary for them. So this suggested to us by using low dose interventions, low dose behavioral treatment, low dose medication, we can get the best bang for the buck in treatment for kids with ADHD. So the next study of that was done in the STP setting was to see if we could replicate that in the school year setting, and we did. We did that, and that was published in Journal of Clinical Child and Adolescent Psychology. So we showed that we could, in acute trials, we could do really good behavioral intervention, and really good combination of the two, which was the most efficacious and least costly intervention for the kids. We, at that time, got interested in a type of treatment design called adaptive treatment designs. We were lucky enough to have worked directly with the group that developed that approach at the University of Michigan. And in that approach, we were able to actually look at sequencing of treatments and combinations of treatments and do it in a real world setting. So we did a study in which we recruited 150 ADHD children to be in this intensive treatment program. And we treated each kid for a year. They came into the study, got treated for a year, and the design was this. All the way to the left in this graphic, it says random assignment. Kids got randomly assigned to either start their treatment with behavioral intervention first, or to start their treatment with medication first, because that was one of our important questions. Our STP, our summer treatment program study, had shown that they both worked, and combination treatment worked, but didn't allow us to ask, what if you started with one, did you need the other? And if you have one in place, can you use a lower dose of the other? So that's what this study was designed to do. In these designs, you have several different levels of random assignment. The first random assignment in this study was that the child would start treatment with behavioral intervention or start treatment with medication. And we elected to make the dose of treatment with which they started a low dose of treatment. So we did that for 8 weeks. Each child got randomly assigned and treated either with a low dose of behavioral treatment for 8 weeks or a low dose of medication for 8 weeks. The behavioral treatment low dose was a limited number of parent training sessions. So 8 group behavioral parent training session and a teacher visit to establish a daily report card at school. So a low dose of behavioral consultation. The dose of medication was a low dose of medication, 0.15 milligrams per kilogram of methylphenidate per child. In the adaptive design, one starts with a low dose of treatment and provides treatment, and then monitors children constantly to see how they're doing. And if a child is doing fine, then you don't add any more treatment and you don't increase the intensity of the treatment that you're using. If a child is having problems, then you step up the intensity of treatment. And in the design that we chose to use in this study, we went 8 weeks with the first level of treatment and then stepped up the intensity depending on the child's response. If a child was having insufficient response to treatment, then we added the other intervention to their treatment. So if a child started with BMOD, he was doing pretty well, but still had problems, then he would get medication added to his treatment, or he would get more intensive BMOD added to his treatment. So in the adaptive study, it was monitoring the kids' functioning. If they're having difficulty, give them more treatment depending on what their assignment was. They were assigned to get more of the same treatment, or they assigned to have the other treatment added in. So that lets you look at in this case, all the possible combinations of behavior mod and medication. You have a group that got behavioral, and then if they needed more treatment, then they got medication added. You had a group that got behavioral. They got behavioral, and if they needed more treatment, then they got more behavioral. You had the opposite. You had a group that started with medication. If they needed more treatment, then they got either medication added or behavioral added, depending on the randomization assignment that each child had. And that leaves you with 6 groups at the end of the study. You had kids who we continued to assess. They did fine after 8 weeks. You continue to, so they didn't need any more treatment and didn't get any more. You continue to assess them monthly, and if they needed treatment, then you randomize them at that point to either get more of the same treatment or the other treatment that they didn't start with. So then you end up with people that started treatment you end up with people who started with medication and then had behavioral treatment added in, or people that started with behavioral treatment and then had medication added in, or the opposite. And we followed the children, treated the children and followed them for a year and looked at what was the most effective combination of treatments for children. And this graph shows pretty quickly what we got. And we were astonished at the results. It's very hard to do a study with behavioral treatment of ADHD where behavioral treatment is better than medication. Medication is very potent treatment. The effects happen right away, and they're pretty potent effects. We were shocked to see in this study that the treatment that was best from the beginning was kids that started treatment with behavioral treatment first. It was better than kids that started with medication first, no matter what else happened in the course of the study. If there were children who started with behavioral and then were re-randomized to more behavioral if they needed more, that was a very good group. This is classroom rule violations and out-of-class disruptive events. So this is direct observations of the kids' behavior in the classroom and school. So this is kids who started with behavioral, and when they needed more treatment, they got randomized to behavioral. These are kids who started with behavioral. If they needed more treatment, then they got randomized to medication. This is the opposite. These are the kids that started with medication, these two groups, and they get randomized to either have behavior modification added or more medication added. And the take home from this study is these two groups are much better than these two groups. So starting treatment with behavioral intervention was much better than starting treatment with medication, no matter what the next assignment was for kids. That was a shock for us because it's really hard to beat medication. But this study showed really clearly what the current guidelines now suggest for ADHD, and that is you should always start with a behavioral intervention and then add medication if necessary, not the other order. Okay, so that was the bottom line of that study. Now, the other thing that we could do with this study that was really important is look at the costs of the treatments, because we very carefully implemented every aspect of the study in such a way that we could measure the cost of what we did. So we could look at whether any one of the treatments was more cost effective than the other. And interestingly, it was a very clear outcome that the psychosocial treatment, the behavioral treatments, were far more cost effective than the pharmacological treatments. So what this study showed was that starting with behavioral treatment is better than starting with medication. Adding more behavioral treatment is better than adding medication. And the cost of those interventions is far lower than the cost of providing medication for kids with ADHD. That study was published 4 years ago in the Journal of Clinical Child and Adolescent Psychology. Okay, now, I have 7 minutes, is that correct?
Yes, that's correct.
Thank you. Okay, so that study summarized 15 years worth of research to do that one study. And that study was the first successful adaptive design study done in child psychopathology. And it really showed us exactly what we wanted to know. However, it also introduced some new domains in which we knew we needed to work. One was looking at the effect of medication on kids' academic functioning. We had another study going on while we were doing that study. It was just a medication study where we were looking at whether or not medication produces tolerance in kids and how one should be dealing with tolerance in kids who are medicated. And we were particularly interested in how medication was affecting academic functioning, academic performance. The first study of those was a very small study that looked at whether medication helped kids' homework performance. And the reason we did that study is that Johnson & Johnson was advertising that Concerta would help kids do their homework. And that had not been our experience. So we actually did a study to find out whether taking Concerta enable kids to do their homework better, and it turned out that it doesn't help them do their homework better. But it did make us interested in the effect of medication on academic functioning in the classroom. Does medication help kids with ADHD help kids with ADHD in their classroom functioning. And this study was published, since I'm not going to be able to get through a lot of this, I'll just tell you it was published in Journal of Consulting Clinical Psychology 2 months ago. It's a very nice study, very nicely done, that looks at whether or not medication helps kids learn new academic material. We've known for ages that medication helps kids be more on task in a classroom setting, helps kids do simple seat work better in a classroom setting. We have not known whether medication helps kids learn new content, new academic content that their teachers are trying to teach. And this study enabled us to do that. And I'll just give you a quick result. A big study, lots of kids in this, doing a crossover study in the STP setting, where we manipulated what they had to learn in the classroom setting, what the teachers tried to teach them in the classroom setting, in such a way that we could find out whether medication helped them acquire new academic skills. Not just did it help them behave better, not just did it help them be on task more, but did it help them learn new material? That's the goal of school, is to learn new material. And the big question for stimulant medication for decades has been, does stimulant medication just improve your productivity in the classroom, or does it help you learn better? Is it going to help your grades? And is it going to help you achieve in school, as opposed to just be more productive in the classroom on a daily basis? And we were shocked at the results. The results in yellow here is there were no effect of medication on the amount of academic material, new academic material that the kids had to learn. Absolutely no effects of medication. That's what the graph look like. So you can see the pre-test and post-test scores for kids who are medicated versus kids who are on placebo over a 3-week period where they're taught an academic subject content area. We did social studies, science, and vocabulary. That's despite the fact that the lower graph here shows you that the classroom behavior of the kids and their productivity in a seat work task, it was much better if they were medicated than if they weren't. But those increases in productivity and behavior did not transfer or translate into learning the material that you were presented with better. What that made us realize is that our interventions in the classroom setting for kids with ADHD needed to move in the domain of how can we help them learn more, not just behave better in the classroom, but how can we help them learn more? So I would encourage you to go to JCCP, the lead article in the June issue last summer, and read that paper. It's a very interesting paper. And I got 2 minutes left. I wanted to show you, I don't think I'm going to be able to get to this, which is terrible, because what you can do if you have any contact with Marcella is ask her about it, because it's a study that she did the analyses on. And what the analyses showed was that it's too complicated to go into, but I'd encourage you to ask Marcella about that. And basically what we're interested in, now that we've learned that medication doesn't help learning at all, the question is, how do we figure out how to help kids with ADHD learn? And is there a way that medication might help? And are there any potential negative aspects of kids taking medication while they're learning behavioral treatment and learning new academic materials? And that's what Marcella's most recent analyses were starting to look at. Does medication undermine the uptake of behavioral treatments and learning treatments? And at some point, how does that happen? If it does happen, how does it happen? And what can we do to overcome the potential iatrogenic effects of medication on behavioral treatment and learning in kids in school settings? So I'll finish with, in -8 seconds, I'll finish with this slide, which is the implications of these treatments. And basically it's that we want to focus on daily life functioning in the kids and their impairments, and not DSM symptoms. All of the guidelines, SDBP guidelines and AAP guidelines, say start with low dose behavioral treatment. And academic interventions in classroom settings and add medication after the other treatments have shown not to be effective. And use a low dose of medication whenever you use it, not a high dose of medication. Use only as much as you need to overcome whatever the difficulties are. And do not use medication as the first line treatment. So that is the single biggest problem we have now in pediatrics, is that we don't get kids referred by pediatricians who've not already been medicated by the pediatrician. And that's a very bad way to start treatment for kids with ADHD. Don't start with medication, start with the psychosocial treatments. And these are just some additional clinical recommendations. So, so thank you very much for listening. I hope you learned something. And as I mentioned to the coordinators of this, I'll be happy to send all these slides and all the slides I didn't get to anybody who wants them. My email address is wpelham, W-P-E-L-H-A-M @fiu.edu. Ask for the slides and I'll send them to you. And also go to our website at Center for Children and Families at FIU. And I'm only 1 minute late, according to my watch. So thank you very much for asking me. And is it too late for questions now, Michelle?
No, it's absolutely not. So if there are any questions, feel free to ask them aloud, or you can post them in the chat and I will moderate.
Go for it, Danny.
All right, Bill, thank you for, as usual, I've heard you do this now for 35 years, and every time you do it is a great update, so thank you for that. One of the questions that comes in, especially in this last point in terms of the sequencing and the combination of therapies, is that I say this often, it's when, not if, there is a change probably coming out of Centers for Medicaid and Medicare to start with, but will influence private insurers, where payments are going to shift from units of activity to outcomes. And how do you see the data that actually are really compelling and deep for the treatment of children with ADHD fitting into that kind of outcome model? And what kinds of shifts do you think clinically will take place for that to happen?
Well, that's a great question, and I'm glad to see some change like that, actually, because that's the goal, is the outcomes that we want to focus on. Actually, the first thing to say is we do not want to give a symptom checklist of the DSM symptoms of ADHD as a measure of outcome. We want to look at the daily life functioning problems of kids with ADHD, and I hope that when those regulations get written, that's the focus that people will take. And if they do take that focus, it will turn out to be the case that psychosocial treatments are far more effective than other treatments. The second thing is that if it is going to be a cost question, the cost of the behavioral intervention that we used in our adaptive treatment study was far less than the cost of the medication. Cost of stimulant medication for ADHD now is enormously high. I think one pill of any one of the long-acting stimulants is somewhere between $7 and $9 a pill. So that's $7 and $9 a day. $7 and $9 a day. That's a therapy session a week. That would pay for a full parent treating session or teacher consultation every week if you weren't giving the child medication, or if you reduce the dose of medication. So I'm happy to see changes like that occur. As you know, ADHD is not something that most insurers have covered at all, including Medicaid. So if Medicaid is going to start covering treatment for ADHD, that's great.
We have a couple of questions in the chat. The first question is if any of this research has been conducted with adults.
No, this is all kids. I'm a child clinical psychologist. And what I do though is do lots and lots of parent treating. So I work with parents of ADHD kids, but not ADHD kids who are grown up. The problem with ADHD kids who are grown up is that they have the same kind of attributional bias they had as children. They don't think there's anything wrong with them. So most ADHD children who grow up and leave the household, so their parents are no longer there monitoring them, those people don't think they have problems. So they don't go to mental health facilities to seek treatment. So the world is that most adults with ADHD who are seeking treatment are mothers of ADHD children who believe that they have ADHD and they discovered it because their child had ADHD. Those are the most people that are getting treatment right now. If you look at our summer treatment program, that's absolutely the case. So I'm a child person, and I don't think right now I would go so far as to say, I don't think it's important to think about how to treat adults with ADHD because most of the ones that need the treatment don't come in for treatment. They don't believe they have a problem.
We have another question here that as clinicians, we find that many parents ask if their ADHD child should be evaluated, treated by pediatrician, neurologist, or child psychiatrist. Can you give information in this area?
That's kind of a loaded question, given that there are pediatricians, neurologists, and child psychiatrists all on your faculty. So I'm not sure. I think what the SDBP and AAP guidelines would suggest is that it doesn't matter what the nature of the training is, follow the guidelines, because those guidelines are the same whether you're talking about a neurologist or a pediatrician. I can say that for our summer treatment program, for the last 2 years, since the Society for Developmental Behavioral Pediatrics guidelines were published, the new ones, which were adopted by the Professional Association for Neurologists, that the number of referrals we have gotten from neurologists has dramatically increased for behavioral treatment. So neurologists in Miami are following treatment guidelines for the Society for Developmental Behavioral Pediatrics, which is really good to see.
Jeff Brosco, you have a question.
Yes, can you hear me, guys?
Yes.
So, Bill, thanks again for a wonderful talk. You're, as Danny said, you're just a font of wisdom and information on this. One thing I wanted to point out to our pediatric residents is that when we talk about the big three, little three, and trying to decide about function, that's exactly what Dr. Pelham has been talking about. So when he says impairment, you're thinking the big three. That is, how is a child learning, getting along with their peers, and getting along with grownups, which means following the rules. So, Bill, the question I have for you is along the lines of what Danny said, which is, you can only see so many kids, and there's probably, 10 or 20,000 children in Miami-Dade County who need a good behavioral intervention. So how do we get to scale, especially with things like daily report cards in school? You would think the school system itself could do that, but it seems like their 504 plans typically are more about preferential seating and stuff that probably doesn't work. Any wisdom on how we could at least move the school system toward an evidence-based approach?
Well, we were lucky to have been successful on a grant submission to NICHD to actually look at all the common accommodations for kids in classroom settings. And I think what that's going to show is that none of those accommodations work. And school districts need to just quit doing that and just do good classroom management and good academic instruction to help the kids. So that's a great question. And in terms of the impairment, it's parent training. If that's one of your big three, it's teaching parents how to be better parents and trying to do it perhaps less intensively than we typically have. So I know a lot of people do parent training and try to get 10 or 15 sessions of individualized parent training. We stopped doing that in our clinic a while back because it was just too expensive. We couldn't figure out how to do it in a cost-effective manner. So all of our parent training has been group parent training for quite a while now. And I know you guys do both. You do some group parent training and you do individual parent training also.
Thank you again, Dr. Pelham. We have run out of time. If you are seeking continuing education credits, the CME code is 113810. And please make sure to complete the survey that you will receive when this webinar concludes.
And can I
Thank you,
say,
everyone.
can I say thank you to Jeff and Danny and Dr. Brasco?
Yes, please go ahead.
I just did.
Thank you.
Thank you.
Awesome. All right. Well, have a great day, everyone.